Hi, and welcome everyone. I want to join all of the folks who are coming in from online. Welcome to the North American Cystic Fibrosis Foundation conference that we're going to be live streaming today. We have Dr. Merlo here today to talk to us about some of the myths around lung transplant. And if any of you tuned into the live stream earlier and were able to watch Dr. Joe Paluski, you might recognize some of these myths from his presentation. So Dr. Merlo is from the Johns Hopkins University. Do you want to say hello?
Sure. Hi. Thank you very much, Piper, for this opportunity. It's the first time I've ever done this, so I'm really excited to be here and to talk about some of the myths that Dr. Paluski had brought up in his plenary today. And for those of you who haven't had the opportunity to watch that, it will be available later on, and you should look at that after this.
Wonderful. So the way this is going to work is I am just going to state one of the myths as a statement, and then I'd love for you to sort of respond to those myths as we go through them.
Sure.
So the first one we have is that patients who require mechanical ventilation are not candidates for a lung transplant.
Yeah, so this is a difficult question. You started out with a difficult one here. This is something that does come up when I speak with patients. And what we know is that years ago, some patients who got sick, who their lungs had failed, may have needed to be on a ventilator, a respirator, a mechanical ventilation to help support them. And we got nervous about that because usually they were very, very sick. We do know nowadays that we are able to aggressively not only treat their lungs with the support of the ventilator, but also help recondition them and make sure that physical therapy afterwards and while they're on the mechanical ventilator can help improve their conditioning. And so it's not necessarily an absolute contraindication. And what we need to have happen is that there needs to be a conversation between the CF team and the transplant team so that we're on the same page. Because if we're all go, then we can make this happen.
And the second myth we have is that resistant organisms and prior chest surgery preclude a lung transplant.
Yeah, resistant organisms, we've studied this, and many centers across the country and across the world have looked at the outcomes in patients who get lung transplants with resistant organisms. And we know that some patients do well. Some patients do well with resistant organisms. We also know that some centers in the United States and in the rest of the world also have experience with transplantation for patients with cystic fibrosis and resistant organisms. So again, this really, really highlights the importance of the CF team talking to the transplant team to make sure that we're all on the same page. If there is a patient out there with a resistant organism, talking to other transplant centers who may have had more experience with this to help guide so that the outcomes are where we want them to be afterwards.
Absolutely. Our third myth is that CF liver disease always requires a combined double lung and liver transplant.
Yeah, so in medicine, nothing is ever 100%, right? And there are a lot of yes-no questions here. And we know that in patients with CF, the lungs are usually what takes them from us. When the lungs get sick, that's what we really worry about. And there are other aspects of the body, other organ systems that are affected, and the liver can be affected as well. Sometimes disease of the liver progresses so that the liver is failing as well. And in that patient population, there may be a reason to have a patient have a lung transplant and a liver transplant. But there are patients who might have a little bit of liver problems. And those patients, not necessarily do they need a combined lung and liver transplant.
And our fourth myth is that lung transplant just magically cures cystic fibrosis and you no longer have CF.
Sure, and this is one of the main questions and one of the main conversations that I have with patients about their cystic fibrosis when patients need a lung transplant. I'm not only a cystic fibrosis doctor, but I'm also a lung transplant doctor, and so patients will come in and say, well, you know, I'm going to get a transplant, and it's going to cure my CF, right? And I say, well, it will get rid of CF in the lungs. However, we know that CF affects many other parts of the body. The sinuses, the GI tract, the liver we just talked about. And it's important that we make sure we take care of the other aspects that CF affects. Nutrition, I didn't mention that. And again, this is where the CF team needs to really partner with the transplant team. And many centers across the country and around the world actually have their patients with CF follow up with the CF team after their transplant to make sure that the other parts of the body are taken care of as well.
It's not just the lungs.
Not just the lungs.
Our fifth myth is that survival after having had a lung transplant is limited to 9 years.
There's a lot of information on the internet, and this is the main thing that comes up with patients and their families. I'm only going to live 9 years, so why would I do this? Those numbers are based on statistical calculations, and we know our patients are not statistics. And I have a patient who's almost 25 years out after her lung transplant and doing fine, 100% lung function, and able to do all the things that she has wanted to do in life. Some patients don't make it as long as we want them to, but we all have success stories of patients living longer and longer and longer. And the one thing I wanted to bring up is that the Cystic Fibrosis Foundation has committed an enormous effort to help improve the outcomes, not just for patients with cystic fibrosis, but for others who require a lung transplant because of their lung disease, to help improve the outcomes. So that same graph that we see every year of improved survival with CF, I think the goal is that we have a similar graph so that 10 years from now, we're not talking about 9 years, we're talking about 20 years. And that's where the foundation has really committed to make this happen.
The sixth myth is that patients who undergo lung transplant are then unable to return to work or school or travel or sometimes even have children or pets.
Again, this is also something that comes up in the process of the conversation about a transplant. Many patients have said, why would I do this? I'm not going to be able to finish school. I'm not going to be able to work. I'm not going to be able to go places in the world that I want to go. And we'll say to them, absolutely not. I have patients who have gone back to work in the healthcare profession. I have a patient who has run a marathon. I have a patient who won the gold medal in the Transplant Olympics for table tennis. I mean, these things happen, and the ability to do things after a transplant should never be limited by the things you read on the internet, because patients are able to do many of the things that they want to do afterwards.
So what you're saying is even if you're not a gold medal athlete before transplant can turn you into a gold medal table tennis player. Huh?
I don't know that. I don't know about that. She was probably pretty good before.
All right, so our next myth is that I am too old to have a transplant.
In years past, there were clear-cut guidelines limiting age as a factor for transplant. As time has gone by, we've extended that upper limit of age. There are centers in the country and throughout the world who are performing transplants on patients who are even in their early 70s. Most of our patients with CF are younger than that. I know that we've had a couple patients who are in their mid to late 60s who have had transplants and have done well. So the age is not an absolute factor that we need to limit patients by.
The eighth myth is that my lungs will never recover if I get rejection.
The conversation that we have with patients prior to a lung transplant, we have to talk to them about some of the potential complications afterwards. And mainly that surrounds infections because of the medicines that we give them to prevent their body from attacking the new lungs, and rejection. Most patients that I talk to become very nervous about rejection. And what I tell them is rejection happens. It can be a bump in the road afterwards, and it's something that we have to deal with. But as we learn more and more about treatments for rejection and we gain better experience and more therapies, there's no reason that we can't tell patients that your lung function and your lungs can recover after rejection. We just need to identify it and treat it properly.
So thank you for helping us dispel some of those myths. And what we're going to do now is we're going to put you totally on the spot, so I hope you're ready for it. And we're actually going to answer some of the questions that our community has given us through Facebook Live. So hope you're ready for this. The first question that we have is, do you have a time frame that CFRD, or cystic fibrosis related diabetes, will be discussed?
Sure. In our CF clinic, we talk to all of our patients about the potential for cystic fibrosis-related diabetes. We know that the prevalence, or the percentage, the number of patients is probably increasing. The more we look for cystic fibrosis-related diabetes, we're finding, especially in the adult population. There are medicines that patients take after transplant that can increase the blood sugar and can increase their likelihood of developing cystic fibrosis-related diabetes. So the conversation happens before transplant in CF clinic. It happens during the evaluation process. And also there are screening methods and conversations that happen afterwards as well.
Great. Our next question is there research being done to look into correlation and development of post-transplant cancer with possible causes? And that comes to us from Paul.
Well, thank you very much, Paul. This is also a conversation that, as a CF care provider and a transplant physician, I do have a conversation I have with patients beforehand. Not only is there a risk for infection and rejection that we have to talk about, but there also is a risk for cancer after a transplant. Most of that risk surrounds the fact that patients take medicines that suppress or bring down their immune system. And because of that, that also increases the risk for cancer afterwards. There are some viruses also that can increase the risk. Most centers around the country and in the world screen for those viruses, so that if we find them, we're looking for treatment and for surveillance for cancer.
Another question is, why does being female hurt the survival rates, or if it does, in transplant?
Right. Having a daughter myself, I think it's always troubling to have a woman out there think that survival will be impacted by gender. I don't necessarily believe that just being female hurts survival. Years ago, studies looked at gender and transplant survival, and there was some thought that gender may affect survival. It may have been that lung size may have had an impact on that. We know that when larger lungs are transplanted into a person who has a chest size that's a little bit smaller than that, we know that survival is better. So big lungs are better. And it may have been that way back when we were doing and looking into those studies, it may have been that we just weren't paying attention to the lung size. We were just looking at gender, and that may just have been a confounder there.
So our next question comes from Crystal, and it is, what is the importance of exercise for transplant patients?
This is a great question, Crystal, and that's one of the most important things. I went to medical school, did my residency, fellowship, training after this, all these years of study, and I think if I just think back about what my mother told me, eat well, sleep well, exercise, and don't do anything to hurt your body. Those are the main things that will keep anyone healthy. And so after transplant, exercise, taking your medicines, and doing the right thing are some of the biggest factors that can help you live a long and healthy life afterwards.
That's a really good reminder. I feel like I should exercise more.
Me too.
So our next question is, why can't post-transplant people and people with cystic fibrosis who are pre-transplant get together?
I don't think that this is I'm going to be careful with my answer here, because I think there are many centers in the United States and many centers around the world, and each center may have their own specific guidelines. I don't think it's necessarily a hard, fast rule that someone with a transplant can't get together with a patient with CF. However, we have to be very clear that there are no potential risky infections that can be transferred. We do have a mentoring system where if a patient who is undergoing an evaluation for transplant wants to speak with a patient who has had a transplant, we will set that up. But usually that's a phone or a FaceTime or a Skype or a video conference. There may be other centers around the country and worldwide that have different rules about this. But again, this really highlights the fact that the CF team and the transplant team and the patient and their family needs to partner and talk about this beforehand.
Wonderful. Well, Dr. Merlo, that concludes our time together here. Thank you so much for this wonderful conversation and for helping us to dispel some of these myths and answer some questions. I want to thank everyone who tuned in from the community. We love being able to talk with you live from the conference. And I also want to reiterate what Dr. Merlo said, and if you haven't watched the second plenary, which was on lung transplant, if you're interested, that was live streamed, so it will be recorded. So thank you, Dr. Merlo.
Well, thank you very much, Piper, and really tune into Dr. Paluski's presentation. It was very, very, very informative.
Wonderful.